I would like to welcome Anique Ducharme, who's professor of medicine at University of Montreal. She's the head of the heart failure clinic, and she's really involved at Montreal Heart, leading the effort about the hypothermia effort. So she will be discussing the best practices of hypothermia. Anique?
Thank you very much. So, unfortunately, I have no disclosure, so for the industry, I'm here afterward. The learning objective I had was basically to review very briefly the physiology which brought therapeutic hypothermia in the clinical field. Then we're going to understand, a few years back we were talking about hypothermia, now it's TTM, so what's the reason for that? And I'll give you a few data from our own center. So this is data from the US. If you have a little less than 500,000 sudden cardiac death, about 2/3 of them, there's no attempt for CPR, and oftentimes this is reasonable. You're in long-term care or things like that. But then if you look, the one who have attempted CPR and those who make it discharged to the hospital, and then who make it discharged to the hospital but with no severe neurological deficit, this is 3% of these out-of-hospital sudden cardiac deaths. So we still have a lot of work to do. So this guy was born like that, but we want our patients to be a little brighter than that. So I have two pictures from my vacation. Well, you saw another one on Graham's talk, but if you had to code today, would you prefer to code in the Bahamas, in beautiful Columbus Island, or in the Chic-Chocs where it's -35 in Gaspésie and you are backcountry skiing? Who wished to go in the Bahamas? And who wished to go in the Chic-Chocs? Okay, you're right, because your chances of coming back alive are much higher. And we've known that. In fact, Napoleon was a great scientist, as you might know. He had troops in Russia and in Northern Africa, and he realized that troops were dying much more in Northern Africa than in Russia. So they started to cover the soldiers who were injured with snow with the hope of having a return of spontaneous circulation. So they did that to all the wounded on the campaign in Russia. And somehow we forgot about that until about a little more than 60 years ago, where there was a first reported case of hypothermia. Then it was used in neurosurgery 10 years later. They were cooling very, very much the patient, and it was abandoned because of all the complication due to very severe hypothermia. And then if you can get rid of my face, you can see that the interest was revived in the 90s because we had a lot of preclinical studies showing some benefit with mild hypothermia. We're not looking at minus 17 or things like that. We're really mild hypothermia. And this is a picture of the brain capacity according to temperature from the 40 to 15 in the x-axis. As you can see with the EKG on the upper left corner that you have a normal EKG 37. And as you decrease the body temperature, the brain function decreases dramatically. So the goal of hypothermia is basically, I'm not going to go through all that, but the next to the last line is to decrease the free radical formation after a return of spontaneous circulation. Basically, it is, you had an occluded brain, and then you have all this flow of free radical. You just want to protect this brain from reperfusion injury. There's been 3 landmark trials. The first one was, the first 2 were published 15 years ago in the same issue of New England Journal. First was multi-center but unblinded, 77 patients. Try to publish 77 patients in New England. Have you ever received? That's amazing. But it were all out of hospital cardiac arrest, all VF. It was a weird randomization profile. It was by day. One day it's your hypothermia, second year normothermia, but we're going to come back to that. So they were aiming at 33 degree for 12 hours, and you have to start it within 12 hours of return of spontaneous circulation. The outcome was a good neurological function. I'm going to defer to Dr. Bernard to explain a little more about all those scores, but basically if you look in the blue in the cold patient, you had survival to home or rehab centers, you had more than 30% improved outcome. In terms of mortality, it seems to be less, but the p-value in this small trial was not significant. Same issue, another multi-center blinded, 275 patient witnessed VF arrest. Randomized, this time for 24 hours, 32 to 34, versus normothermia, but you'll see that it was a little more than normothermia what they had. And they looked at neurological outcome again and a bunch of secondary outpoint. If we look at neurological outcome, you see that it was much better. This is favorable neurological outcome, improved by a little more than 30%, favoring the hypothermia, which is 32 to 34 for 24 hours. Mortality here with this trial was 3 times bigger than the first one, was significant with a decrease in mortality of about 30% at 6 months. So that led us to the protocol. Everybody was doing it in a sort of artistic way, and then we developed a protocol, and we say, well, between Europe and Austria, we're gonna cut off between 32 and 34, and we were aiming for 24 hours. Then we thought everything was done, and it was my hat of the head of the resuscitation team at the hospital, but 3 years ago, this paper comes out. They compared 33 to 36. Multi-center, 950 patients, 3 times more than the 2 previous trials. Out of hospital cardiac arrest, any rhythm on arrival. And it was randomized 33 for 36 hours, I'll explain later, or normothermia, but normothermia is 36. This is very mild hypothermia and certainly not hyperthermia. And then there was a rewarming phase for about 12 hours where you increase by 0.5 degrees per hour. So you try to avoid the hyperthermic that you might have once you take off the blankets or whatever cooling method you're using. Importantly here, the neurological assessment was blinded, and they look at all-cause mortality. There was some poor outcome secondary endpoint. And just to look a bit, and this slide, it's a bit busy, but I've highlighted what I think is important. 80% were shockable rhythms, so you have 20% that were non-shockable. And more importantly, I don't know if we can see from here, the start of BCLS was within 1 minute. Start of ECLS within 10 minutes. I think if somebody codes here just for Urgence Santé to get through, it will take an hour. So this is amazing pre-hospital care. And we can see that the resuscitation was quite efficacious. Lactate after return of spontaneous circulation, 6, which is pretty good. Only 15% were in cardiogenic shock and 40% were STEMI. So if you look at in green, it's 36-degree group, and in blue, 33, and they achieve with all the new technology pretty good cooling up to the level we were looking. The red line is at 37, which is normothermia. So basically, it's not normothermia, it's controlled hypothermia. And when this paper was published, a lot of people, you know, inertia is like a very strong disease in the medical field. They say, oh, I don't have to do anything, like normothermia is the same as hypothermia. Those patients were very well controlled. They were at 36, they were not at 37, not at 38. So it was really what now we call targeted temperature management. It's mild hypothermia, but you have to control especially the hyperthermic phase. So the blue and the green in terms of survival are exactly one over the other. So 33 or 36 is the same. And this is busy, but all these secondary subgroup analysis all the P were non-significant. So there was no group that you can tease out that would do better at lower temperature. So it was tough to reconciliate. This is the mortality data from the ACA trial, from the Bernard trial, where you see that in red, no cooling, 36% survival. And now we reach 52% survival. What caused that? Is it probably the bundle of care that was led by Graham. Yeah, the ICU care is much better, but they were taking care within a minute of their initial cardiac arrest. There was a witness, and there was patient where BCLS was started right on the field. And then we have the same at 33 or 36. So the difference in the control group, on the left is the Nielsen study, the TTM. I've shown you this slide already. On the right side, the control group, the average temperature was 37.6. This is not normothermia. This is being febrile. And in Bernard, it was about a little above 37. So there's a large difference in maintenance of temperature between the three groups, on top of the bundle of care that is improved. So the editorial that joined this paper said, it's the largest trial conducted so far. Patient selection, it's much less. That means we have 20% of non-shockable rhythm, but very, very good pre-hospital reanimation. Modern ICU management, but it does reinforce the importance of TTM. Many patients in the other studies were hyperthermic, which is deleterious, and what I would like you to remember is that whatever the mechanism, it seems clear that we should not regress to pre-2002 style of care that does not manage the temperature at all. And we had some sort of that switch in our hospital, especially when we had new fellows in July coming in. Why should I cool this guy? It doesn't work. It is TTM, and you have to aim 36. So let's see what are our results at Montreal Heart Institute. We reviewed the chart. We want to have 1 year follow-up, so from 2008, when the protocol was well working, to 2015. And we looked at the long-term follow-up and the neurological function. And our patients are young, because you, the clinician, decide either if I cool this patient or not, so we don't have the denominator of all the patients with out-of-hospital cardiac arrest being transferred to our hospital. A mean age of 60, the vast majority out of hospital. Like Nielsen, we have about 20% non-shockable rhythm, and 2/3, probably because we're an angioplasty center, were ST elevation MI, and 1/3 cardiogenic shock. If you look at the probability of survival to discharge, it's pretty similar to Nielsen. We have about 40% in our population. If we look at the patient who are discharged long-term, basically they don't die. One, they're discharged within a month if they either die or select themselves as living, and then they go on for at least, here we have almost 7 years of follow-up. In terms of neurological outcome, in blue is in hospital when we discharge a patient, and in red, the long-term follow-up. And you can see that some patients do improve over time, usually within the first 3 months. And this has been presented at the AHA by one of our fellow, Nadia Boulay-Lagazi, and hopefully be able to present the paper soon. So our experience is real-life setting. We have good outcomes. They are, in fact, similar to those obtained in randomized controlled trials. And we had only 80% shockable rhythm. We tried to compare between the era of aiming at 33 and aiming at 36. There was a trend for a better outcome at 36, but numbers are so small that that p-value was far from being significant. And the long-term neurological outcome seems to improve at the long-term after discharge. So thank you very much.